By 2030, South Asia is projected to successfully exceed the UN's primary healthcare target, reaching 81.5% coverage across the region. But over the exact same timeframe, catastrophic health expenditures are projected to more than double, hitting 18.6%. Expanding access to clinics and treatments without providing adequate risk pooling forces patients to pay out of pocket, actively pushing households below the poverty line. To avert a regional crisis, health ministries must immediately shift their focus from merely expanding access to implementing robust financial protection. This chart tracks the Composite Coverage Index. The bottom right panel plots South Asia's steady upward trajectory toward the 2030 target. Sri Lanka and Bhutan drive this average, projected to exceed 90% coverage. Conversely, Afghanistan and Pakistan will fail to reach the 80% benchmark. In both nations, prolonged political conflict has severely disrupted healthcare delivery, compounding years of systemic underinvestment in primary care infrastructure. Hitting these coverage benchmarks requires both high per capita government expenditure and a stable operating environment. For catastrophic health expenditure, the regional aggregate climbs sharply to 18.6%. The most severe shocks occur in Afghanistan, spiking to 49%, and India, jumping to 26%. The widening gap between the green and blue trend lines demonstrates rural households face significantly higher financial risks. When governments expand care options without absorbing the costs, medical treatment becomes a financial trap for vulnerable rural citizens. The data proves that public health insurance and centralized government financing are the most effective mechanisms to lower these out-of-pocket costs. Bhutan and Sri Lanka fund care through general revenues, insulating populations from medical bills. India uses targeted public insurance, absorbing hospital costs for its bottom 40%. Without interventions, patients pay out of pocket, accounting for roughly 74% of health funding in Afghanistan and Bangladesh. Relying heavily on out-of-pocket payments directly contradicts the core premise of universal health coverage. Moving forward, health ministries must prioritize financial architecture with the exact same urgency as physical clinics. First, governments must drastically increase per capita primary care budgets, specifically targeting lagging and conflict-affected zones. Second, policymakers need to scale publicly funded insurance to cover rural demographics. And third, systems must transition towards centralized, tax-based risk pooling. Healthcare access without affordability is not universal coverage.